talking to you all about correlations between different screening methods for diabetes in patients with transfusion-dependent thalassemia. So I'm sure we all remember what diabetes is from the journal clubs, but the important thing to know is that hemoglobin A1C, which is the current gold standard for screening, is not at all reliable or efficient for patients with transfusion-dependent thalassemia. And this is because the hemoglobin in their bloodstream is not their own, so it's not the most reliable representation of their own body's ability to regulate glucose. So instead, the two methods that are used are fructosamine levels and oral glucose tolerance test. And fructosamine is significantly newer than OGTT, which is why it's so important to establish a relationship between the two to see if fructosamine is a more viable alternative to OGTT, since it's just significantly less cumbersome on both the patient and the provider to do. So the objective of this specific project is to determine the correlation and then discuss factors that may be influencing correlations or inconsistencies between the screening methods. And the way we did this is through retrospective data analysis, where we categorize the data into a consistent and inconsistent subgroup based on whether or not the fructosamine level and the fructosamine abnormality at the last fructosamine test match the abnormality of the OGTT test from that same day. And after categorizing the data, we used t-tests and regression models to basically determine if any patient characteristics could have been influencing the inconsistency that we saw. And in terms of the actual cohort characteristics, we had a pretty even split in terms of sex. And in terms of diagnosis, we mainly had beta thalassemia major because it is the most commonly seen diagnosis for transfusion-dependent thalassemia, but we did have representation of other diagnoses as well. In terms of the mean age, we mainly had adults or middle-aged patients, which is important to take into consideration because your care gets vastly different as you age, and because they have been transfused for longer and have been on chelations for longer, there is a higher chance of them developing endocrinopathies such as diabetes because of iron accumulation. Additionally, mean ferritin and mean fructosamine were a lot higher, and in fact the mean fructosamine was very close to the cutoff for abnormality. Additionally, in relation to the cohort ethnic backgrounds, we had a pretty diverse group, which is important to take into consideration because it means we're more readily able to generalize our conclusions that we're drawing from this project. So let's get to the actual results. So what we saw after categorizing the data is that there were a lot more inconsistent patients than we previously expected. In fact, around 40% of the patients in this cohort were inconsistent. And after using t-tests to look at the patient characteristics, we saw that there was no significant correlation at all except in disposition index. And disposition index is basically a measure of the influx of insulin after consuming the 75 milligrams for OGTT. And it's typically correlated with a higher risk for type 2 diabetes. And basically what this is telling us is that there's a statistically significant higher risk of type 2 diabetes in patients in the consistent subgroup. And after the t-test, we ran regression models to basically see if there were any correlations between patient characteristics within the subgroups. And we saw that in the inconsistent subgroup, there were no correlations whatsoever. But in the consistent subgroup, there was one statistically significant correlation, and that was between age and fructosamine, and it was a positive correlation. So as age was increasing in this subgroup, so was the fructosamine level. And the main conclusion to be drawn from all of this is that fructosamine should be reevaluated as a primary screening method or any kind of screening method for diabetes in patients with transfusion-dependent thalassemia, because we're seeing that the patient characteristics that we looked at in this project were not at all relevant to the consistency itself. So it must have been because of the tests themselves. So moving forward, the kinds of things that we would like to look further into are how correlations and consistency may change over time for a single patient, and explore explore possible causes for inconsistencies in the same patient in the same year, because we had 4 patients we had to exclude because in the same year they went from being consistent to inconsistent and back to consistent. Also exploring how transfusion specificities, such as how long they've been transfused or how big the units they get are influencing consistency, as well as dietary habits, chelators, adherence, etc. And before I sign off, I'd like to just thank my mentor, Dr. Erkin-Cakmak, who was the best mentor I could have asked for. And thank you to SSRP for allowing me to have this opportunity. And thank you to BCH Oakland, Northern California Comprehensive Thalassemia Center, the patients and families from which we got all of this data. And thank you lastly to my high school for allowing me to continue research into the school year.